In my topic is update on acute alcoholic hepatitis, so I try to pick up the recent papers that might influence our practice. So basically the spectrum of ALD is quite wide. Most of the patients drinking harmful amounts of alcohol will develop, even after 2 weeks, the steatosis, which is reversible. But then few of them progress to cirrhosis. It's around 10 to 20%, and 1 to 2% a year will develop HCC. Now, the syndrome of acute alcoholic hepatitis can overlap any of these stages, and probably the extent of the underlying disease might determine the severity of the course. So there's a unified definition of alcoholic hepatitis. The main feature of alcoholic hepatitis would be the sudden onset of the jaundice in patients with heavy alcohol use, which is defined as more than 50 grams a day for a minimum of 6 months. Of course, in our diagnosis, we exclude the other reasons or other liver diseases that might cause the decompensation. Now, the question is, do we need biopsy in routine clinical practice? The answer is probably no. If we are sure, if we have no other cause identified, we should call this as a probable alcoholic hepatitis according to recent guidelines from the United States. If we do have any doubt and if we have transjugular biopsy available at our practice, we can perform the biopsy. Then we call this as definite alcoholic hepatitis. And if we don't have the biopsy at hand, so we would call it possible. Now, our accuracy of clinical diagnosis comparing to histology is almost 96% if the levels of bilirubin are high, which is most of the patients we treat. Assessing the severity in alcoholic hepatitis, we all know we use 4 prognostic models to assess the severity, which will guide us should we or should we not use corticosteroids, and then a dynamic Lille model score, which helps us to decide should we continue with steroids or not. There's a new we want to be most accurate as possible, so we can combine these models, or we can use new kits on the block, which are the new scoring models for newly defined syndrome, acute on chronic liver failure. We don't have much time to discuss that. So briefly, combining the models, if we combine a Lille model with the MELD score, we get the best accuracy. So for example, if your patient after 7 days of corticosteroids, his Lille model is 0.2 and MELD score is, let's say, 21, the probability of the death is less than 10%. Now, the models for acute on chronic liver failure, these patients are the sickest ones you meet in a hepatology unit. And even from our experience, we can confirm this data that occurrence of ACLF is a significant factor that influences the mortality of these patients. You can also predict the response to steroids according to the stage of the ACLF. Comparing the scoring system for acute on chronic liver failure with already known scores for acute alcohol hepatitis comes out that they have even better prediction accuracy. And it seems like we can use it even to differentiate between the severe and non-severe alcoholic hepatitis. Now, the treatment of alcoholic hepatitis since 1978, it's almost 40 years. We still have only one drug, which is prednisolone, that improves short-term survival. None of the other drugs prove this, and none of the medical therapies improved medium and long-term survival, which is very disappointing. The only effective treatment is early liver transplantation, and we'll talk about it in the next slide. Now, what we learned from the huge multi-center trial from the UK, more than 1,000 randomized patients, which was designed to answer the question, do steroids or pentoxifylline works for alcoholic hepatitis? And we learned that prednisone is likely to be effective in short-term mortality, but none of these drugs improved the medium and long-term mortality, as was said, and pentoxifylline failed to confirm that it improves the short-term mortality. Taking all the patients from the 22 randomized trials and assessing the effectiveness of already used drugs and the combination of these drugs, The result is that all of the interventions might be superior to placebo, but pentoxifylline would not be suggested as a first line because of the low confidence in estimates. The most effective seems to be corticosteroids in combination with N-acetylcysteine, but it's only one randomized trial, and then prednisone itself. Now, what else we can use except the steroids to improve the survival? It's nutrition, it's abstinence, and vigorous screening of infection in these patients, because this is what's killing them. Nutrition, very nice trial from Belgium and France. And the question was, does nutrition improve the survival, 6-month survival? And how should we feed these patients? And the results are that oral should be preferred because there was a poor tolerance of the tube feeding, and there was no statistical difference between tube feeding and oral feeding. And the amount of the calories we should give to our patient is over 22 kilocalories per kg per day, because the lower intake was associated with a significantly higher risk of death, infection, and trend towards the hepatorenal syndrome. There's not much studies. Basically, this is the one study that looked at the effect of the abstinence on the long-term survival. So if patients survive episode of severe alcoholic hepatitis and they abstain from the alcohol, there is a statistical significance in survival up to follow-up. Median follow-up was 55 months. Another thing they identified were 2 factors at the admission that might predict the risk of relapse. So there's a high-risk group, patients with more than one treatment in the past of alcohol dependency, and less than 48 years age. These are the high-risk patients, and the recidivism of the alcoholism is more than 74%. And then the low-risk groups. Low-risk group was elder patients and no previous treatment. Infection and response to steroids. We know from the Luvet's paper that response to corticosteroids is the key, and non-responders have much higher incidence of infection. Now, what we learned from the STOP-AH trial is that incidence of infection before the treatment, which is called baseline infection, or on the treatment, is quite high. Less than 50% of infections are culture positive, and more than 50% of isolates were gram-negative. 2 interesting findings. Baseline infection might not be entirely benign, what means that if we treat infection, and we are happy that the infection is resolved, and then we give prednisone to these patients, if we don't continue with antibiotics, the mortality dramatically improves if they take steroids. So suggestion is that we probably should continue with antibiotics even after resolution of infection if we treat these patients with steroids. It did not proved in the patients without steroids, so with pentoxifylline. And another interesting finding is that if we have infection during the treatment, which is incidental infection, if patients are taking steroids, the mortality dramatically worsen. It's almost doubled compared to patients not taking steroids. So is there a tool we can predict the risk of infection if we give patients steroids? And there might be the high bacterial DNA level in patients who were taking steroids was associated with development of infection. So probably in the future, if this tool will be available, we might test the patients, see what's the level of the bacterial DNA, and then decide, are they risky for steroids or should we use steroids with antibiotics? We'll see what it brings. What else? There's some preliminary data in humans with severe alcoholic hepatitis, and I picked up a few which bring some positive results. One is the study with metadoxin, which is antioxidant. This is a study from Mexico, and metadoxin inhibits the lipid accumulation in the liver, and it supports the synthesis of glutathione. So it's not available in Slovakia. According to Wikipedia, it should be available in Russia, Ukraine, Hungary, but I'm not sure of that. But anyway, adding this medication to pentoxifylline or to prednisone, which are conventional treatments, all patients survived longer than patients without methodoxin. And interestingly, patients receiving methodoxin maintained greater abstinence than those who did not receive it. It should be a good option probably in the future, a cheap option. And other studies, proof of concept studies with granulocyte colony stimulating factor, proved that GCSF are effective in patients with alcoholic hepatitis. The point is that the GCSF improves the neutrophilic functions, and on the other hand, it mobilizes bone marrow-derived stem cell CD34, which spontaneously accumulates in the liver and differentiates into hepatocytes, so regenerate the liver. Fecal transplant has thriving results, very small number of patients, only one of them died during the 12 months period. So excellent survival rate after fecal transplant with stool samples from family members, and we have to wait for the larger trials. Now, the most controversial treatment for acute alcoholic hepatitis is early liver transplantation. There's 3 trials published so far, 2 from the United States, 1 from Mount Sinai Hospital, 1 from Johns Hopkins Hospital. These are retrospective studies, but the pilot trial is from France, where the findings we have to learn from is that less than 10% of patients are candidates for early liver transplant because of the psychosocial profile. And the burden on the liver transplant program is quite low. Only 2.6% during the study of all the liver transplanted were used for the alcoholic hepatitis. The results are very optimistic, very excellent. The survival rate was more than 70%. 6-month survival rate was 77% compared to 23% if we don't transplant these patients. Now, the recent study published this year is the largest study with early liver transplant for severe alcoholic hepatitis, including 46 patients, a retrospective study from Johns Hopkins Hospital, and again proving excellent outcomes. It's 97% 1-year survival, and there's no difference between severe alcoholic hepatitis patients and patients with ALD cirrhosis transplanted for regarding even the alcohol relapse rate. Followed these patients for 5 years now. So the question is, should we or should we not? Lots of controversies from a medical point of view. We know it improves the survival. Patients who are not responding to corticosteroids will die. They will die soon. So if we're going to transplant these patients, we have to transplant them very early. I'll leave this question open because we don't have time for such a long discussion. But they did a survey in the French liver transplant centers this year. It's accepted for publication. And you can see the impact of Maturin study. Before it was published, only 35% of physicians would say, yes, we would transplant patients with alcoholic hepatitis. But after we know that the relapse rate is similar to relapse rate in ALD patients, we already transplant. And the survival is same. Now, 71% of hepatologists, surgeons, and anesthetists would transplant patients with alcoholic hepatitis. There's ongoing trials. I'll just fly through it. Ongoing trials focusing on infection using prophylactic antibiotics in alcoholic hepatitis. Again, trials with the GCSF, trials using anti-interleukin-1 receptors or antibodies against LPS. The results should be available in a couple of years. We have to wait for these results. And to conclude, prognostic models are very simple to use and very efficient tool to guide us in treatment of alcoholic hepatitis and to assess the prognosis. Pentoxifylline as a first-line therapy is probably over. Prednisolone likely improves the short-term survival. There's no effective treatment at the moment except the liver transplant to improve the survival of patients not responding to steroids. And the cornerstone of the therapy is prevention and abstinence. Thank you very much.
Thanks a lot for a nice talk. And we have a time for discussion or comments. Please, it's from floor. It's Professor Jančuška.
Jarčuška, Slovakia. One provocative question. What do you think about the using of rifaximin in patients with mild and severe alcoholic hepatitis? Because fecal microbiota transplantation is effective, and microbiota profile is changed in patients with severe alcoholic hepatitis comparing with other patients, and rifaximin could improve the translocation and endotoxemia.
Well, I tried to find the rifaximin trials. That there's one listed in the ongoing trials, but for some reason the recruitment is stopped. So we have to wait for results how rifaximin will affect alcoholic hepatitis. But it has a point, because if you influence the microbiota by the transplant, it might have a point influencing it with antibiotics as rifaximin. And there's another 2 trials which will be finished this year with amoxicillin, it's a French trial, and then ciprofloxacin, it's a Finnish trial. So we'll see, and the Finnish trial is ciprofloxacin for 120 days. So it's quite a long time, 3 months of treatment with antibiotics, and that's influenced microbiota as well. So we'll see the results.
The next question or comments? What about your clinical practice in your side, in the transplantation side? You mentioned that the position of prednisone is a little bit controversial. So benefit short, negative long-term effect. It's your clinical practice. What's the position prednisone in acute alcoholic hepatitis patients?
Well, we use prednisone as a first-line treatment, as recommended. Well, we have to be very careful, and every time you have patients when you give them prednisone, and after 2-3 days the bilirubin drops. But if it rise again, it's usually infection. So you have to be very careful, and you have to watch for infection. And when you have even suspicion, because the cultures are mostly negative, so if you have suspicion, you have to hit them hard with second-line antibiotics, and sometimes they improve. So prednisone is the only drug we use really now. Pentoxifenolin we would use if there's contraindication to prednisone, because we have nothing else to give them really.
Thank you. And the next? Oh, nothing more. Thank you very much.
Thank you.